Good afternoon, and thank you for joining us for this webinar. We've entitled it Infertility, Not Just a Female Condition. And specifically, we're going to be looking at various causes and treatments of male infertility. I'm Dr. Landon Trost. I'm the current head of andrology and infertility here at the Mayo Clinic in Rochester, Minnesota. And again, I'm grateful that you're joining us for this webinar. Well, just as a brief overview, we're going to be looking at the prevalence and importance of male infertility. In other words, how often do we run across the condition? We're going to look at some of the anatomy, the physiology of the male condition and what causes male fertility in general. And then we're going to divide causes of infertility into two things. We'll be looking at specifically obstructive causes as well as non-obstructive causes. Now, there are a lot of different ways you can look at male infertility, but this is a very simplified and easy way to go about looking how we can treat it and so on. Then we'll go into specific treatments for male infertility and what you can expect if you were to come in for an evaluation for it. And then at the end, of course, we'll have time for questions and we'll go through those from online. Well, so the first question that we come across is how common is male infertility in general? For many, many years, people always attributed fertility to be a female condition only. And even today, up to 85% of providers will evaluate the female without even considering the male side of the equation for it. Well, when we look at it overall, couples are affected about 15% of the time. So, roughly 15 out of 100 couples who are trying to achieve a pregnancy won't be able to successfully do so within 1 year of unprotected intercourse. Now, among those couples, the estimates as to the contribution on the male side ranges anywhere from 30 to 75%, meaning that in about a third of cases, it's a male factor only, and about a third, it's a female only, and about a third, it's a combination of the two. Now, beyond the obvious, as far as not being able to have a baby, there are some other important things to consider regarding male infertility. One is that you're at a much higher risk for testicular cancer, for testicular malignancy of any type. That's anywhere from 0.3 to 0.9%, and these increase your risk anywhere from 2 to 20-fold with testicular cancer. Also, if you have 2 or more abnormalities on the semen analysis, that gives you a higher rate of increased mortality. Now, it's probably not the infertility itself that's bringing on these issues, but rather if you have signs and findings of infertility, this may mean that there are other things going on in the body also that may be contributing to these comorbid conditions. We also see increased risk for certain types of cancer, including colorectal carcinoma, melanoma, prostate cancer, and others. So beyond just the infertility side, there are other reasons to seek evaluation for male infertility. Well, when we look at what are the reasons that we try to examine the male side of things, number one is we look, what conditions can we reverse? Are there simple things we can do to go in and make you fertile again? We try to find the conditions that are going to be amenable to these assisted techniques. Now, we call them ART or assisted reproductive techniques. These are things like intrauterine insemination, in vitro fertilization, intracytoplasmic sperm injection, things like that. There are certain conditions that allow you to participate in these, and there are certain conditions that are not amenable to it. So that's one of our objectives with evaluating. We also want to know, do you have any other syndromes that are maybe detrimental to your health? Things such as Klinefelter, cystic fibrosis, or others are common with, or we find more commonly in men who are infertile, and we want to know those syndromes and help you identify them. And finally, we want to look at any potential genetic abnormalities that you can potentially transmit to any offspring. There are technologies where you're able to test and assess for those, and that's one role for the male factor evaluation. Well, when we look at male fertility in general, just some basic kind of facts and background. In the picture on the upper left there, you can see a kind of a cross section of a penis that's cut, a little graphic of it. And you can see one important aspect, of course, with infertility is normal erectile function. Typically, when sufficient stimulation is around, this artery will dilate. It'll fill the cavernosal spaces here with blood. The penis will expand to cause an erection, and it will compress these subtunical venules. Again, this picture is a bit simplified, but then the erection is maintained. Clearly, if there are issues where you're unable to achieve an erection, or if the opening to the end of the penis is on the underside of the penis or things like that, this will contribute. There are nerves that are responsible for erections as well as for ejaculation. In this case, you can see the nerves running behind the prostate, the cavernosal nerves. These are responsible for erections. And there is a whole plexus of nerves that are responsible for ejaculation itself. Men who've undergone pelvic surgery, such as for rectal cancer or other areas where they're in this area of the pelvis, can often have those nerves damaged, and that can result in ejaculation going backwards into the bladder, or at a point where they just can't ejaculate at all. So those are other things that we consider. When you look at the pathway of sperm, so sperm are made in the testicle, and we'll go into that in more detail. They then travel into the epididymis where they mature. They travel down this long coiled tube until they reach the vas deferens. This then goes into the belly, behind the bladder, and joins in the prostate into the ejaculatory duct. There it mixes with fluid from the prostate, fluid from the seminal vesicle, and others. At the time of ejaculation, this fluid is then deposited into the what we call the proximal bulbar urethra. From there, that then stimulates a reflex that then causes you to ejaculate the fluid out. So disruption of any one of these pathways can result in infertility. When we look at sperm itself, it's a little bit detailed of a graphic, but you can see sperm from the time that they start as primordial cells until they develop all the way into sperm themselves. You can see the stem cells up here, the blood-testis barrier, and as they're developing. Well, a couple facts about this. For one, it takes about 3 months to generate a normal sperm. And that's important because any changes you make today, you're likely not going to notice until, again, you're about 74 days into it. So if you stop drinking, stop using other substances, things like that, you won't notice the benefit until roughly about 3 months. There's a constant regeneration of sperm. People are frequently asking, can sperm get too old? Is it better to have fresh sperm versus older sperm? Your body's constantly turning over sperm. And for the most part, you're going to have new sperm that are available with any ejaculate. Again, we talked about any change you make today takes about 3 months to show up in any semen analyses or other testing. And the ideal temperature for sperm is about 34 degrees Celsius. Now, it's a couple degrees lower than body temperature. So especially nowadays where most people are spending a lot of time sitting, there's an increased chance of increased testicular temperature. When that happens, sperm generation, spermatogenesis, all is impaired. So anything we can do to reduce those temperatures can have an impact, spending more time standing, less time sitting. But they are designed for a lower temperature situation. When we go through the hormone side of things, so these are just portions of graphics. So you have the hypothalamus and the pituitary. Down here, this is meant to represent the testicle. The brain releases gonadotropin-releasing hormone. That then acts on the pituitary to release luteinizing hormone and follicle-stimulating hormone. Luteinizing hormone specifically acts on the Leydig cells that are in the testicle, and those produce testosterone. FSH, or follicle-stimulating hormone, on the other hand, that acts more on the Sertoli cells to produce sperm. Now, it's a little more complex, of course, than that. There's interactions that will happen between within the testicle. As far as FSH will also initiate meiosis. It'll increase the production of something called androgen binding protein that helps trap testosterone within the testicle. So there are other interactions that occur, of course. Once the testosterone is produced, I'm sorry, we may have lost here. Here we go. Once testosterone is produced, that then feeds back peripherally. So the fat cells in your body are going to convert testosterone into estradiol via this hormone aromatase. That then goes back to the brain, both testosterone and estradiol, to tell the brain that we have enough. We have enough testosterone. The Sertoli cells produce inhibin that says we have enough sperm, and it helps to regulate this whole process. So now that we know the normal process of male fertility, what are things that can happen to cause male infertility? When we look at, again, a cross-section here, and we break it down by blockage versus production. And this is a very simplified way of looking at male infertility. There are a lot of things that can cause blockage. When you look at the epididymis itself, you can have epididymal obstructions. You can have a vasectomy. Of course, that's usually an obvious blockage, although I still do occasionally see patients who come in and say, I can't figure out why I have no sperm. And then we feel along the vas deferens, and sure enough, they had a vasectomy. That'll cause blockage, of course. At the ejaculatory duct, that also can cause blockage. That can either be something that you were born with, or some men will acquire it from infections where you get blockage of that tube. And finally, a hernia repair, about less than 2% of the time. Sometimes people will get a blockage from a hernia repair that blocks the vas deferens. The nice thing about blockages is that they're reversible for the most part. So we can go in and do some sort of surgery and kind of get you back to what you were before. Now, when we look at the other side, on the production side, There are many causes of production issues, and we'll go into these in a little more detail, and we're only going to touch a sliver of the various causes that can contribute to male infertility. How you can differentiate this. Now, kind of a really quick way to tell in yourself, for example, if you're infertile, is based on the testicular size. If you have normal sized testicles, and if you have access to blood tests where you can look at FSH, LH, testosterone, if those are all normal, that puts you at a much higher likelihood of having a blockage as the cause for the infertility. On the other hand, if you have small testicles, have high blood tests such as an FSH, that would indicate that the testicle itself is having a production issue, and it's less likely to be a blockage. Now, of course, the body's never, always 100% one way or another. You can have either blockage or production can be combined in some cases, so it's not always a definite one way or another. Well, causes and treatments of blockage. So again, men can get epididymitis for various reasons. It can be something that was acquired, something you've had lifelong. Chlamydia, gonorrhea are two common sexually transmitted diseases that we see that cause this. We also can see tuberculosis on occasion, and sometimes inflammation from mumps and other things can cause it too. Recurrent urinary tract infections, or sometimes even reflux epididymitis, so sterile epididymitis can cause this. And prior surgery, such as a hydrocelectomy, other things can contribute to this too. One giveaway on this is often that men will say, I had a period of episodic testicular pain or scrotal pain, and that can be a giveaway that there was some sort of inflammatory or infectious process that may have scarred the tubes for it. When we look at the vas deferens itself, again, you can see a depiction up here. This is a site of granuloma where a prior vasectomy was performed. This tube of the vas deferens, of course, prior vasectomy, prior inguinal hernia repair, certain congenital conditions. So if you have cystic fibrosis, one way we often catch cystic fibrosis is men will come in with infertility and they're missing that tube, or the tube isn't connected like it should be, and that can key you into cystic fibrosis. Or if you have a history of one kidney or had recurrent kidney infections when you were younger, had your kidney removed for some reason, those can also be clues that there's some evidence for obstruction, because oftentimes issues with the kidney will also cause issues in the genital tract or in the testicle itself. Well, vasectomy reversal. So there are a lot of techniques as far as to reverse a vasectomy, but vasectomy can be reversed using microsurgery. There are different ways to do it. Of course, you can do it robotically with the microscope itself. And the pictures you can see there are outlining two different variations on this technique. You can also go to mayoclinic.org. We have some new videos up there that are a little bit better graphics that can go into more detail as to how the procedure is performed. Up on the top picture here, you can see what we call a VV, or a vasovasostomy. This is where you use very fine suture, much finer than a human hair, to put these tubes back together. Down here, you can see what's called an epididymal vasostomy or vasoepididymostomy. And again, you're plugging an epididymal tubule into the vas deferens itself. So depending on the clinical situation, we'll need to use one or more of these techniques for it. Well, one common question I get from patients as well as providers is, I had my vasectomy more than 5 years ago, therefore it can't be reversed. And that's not true. There was one guy the other day who was 26 years out, and you're able to reverse it. However, your success rates will decline over time. So if you get it reversed within the first few years, you have a higher likelihood of having sperm return. You can see from this graphic, and our results mirror these. You have roughly 97% chance of sperm returning, 76% chance of actual pregnancy. As time goes on, if you're over 15 years out from the vasectomy, those rates drop a bit for it. And that more likely reflects the need to do a more complex repair, such as an epididymal vasostomy with this. Well, in some cases, such as a prior hernia repair, a vasectomy reversal is very, very challenging. The scarring for that oftentimes is so high that you can't repair this using traditional techniques. And in my opinion, this is the really ideal time to use robotic techniques to bypass the vasectomy. And in the video, you can see on the bottom right here, we show a technique where the vas deferens is brought within the belly. And I really want to give attention also to Wayne Hellstrom and Dr. Cijo Pericottl for this as well, who participated in the procedure and who were main contributors. You can see here the vas deferens is being brought into the belly from outside. Holding stitch is placed into the vas deferens. We then free up the vas deferens inside the belly. to make it be able to reach that area. And here we're securing the two ends together. And then at this point, we will bring the microscopic sutures in place and do the standard anastomosis to bring it back together. Again, this is relatively uncommon, but it does show that we can reverse issues relating to obstruction in the far majority of cases with the right techniques. And again, I think there's select roles for robotic versus microscopic techniques, but it's nice to be able to have options either way for it. Ejaculatory duct obstruction. So this is another one of those relatively rare cases that is reversible. In the pictures on the bottom left there, you can see as you go in through the opening of the penis and you get to about the level of the bladder, a little bit before that, you can see those areas of blue is where we've shot dye in through the vas deferens to be expressed out the ejaculatory ducts. So those are what normal ones should look like. On the picture on the right, though, you can see what's marked a UC or utricular cyst. You can see an area of blockage for the ejaculatory duct. And in this case, it's a calculus a little bit higher up there that's a bit darker on the picture. That's causing blockage, which doesn't allow sperm to be ejaculated out. And this can be due to numerous causes, stones, infections, prostatic cysts, and so on, and it's relatively rare. But it is a reversible cause. Well, when you look at causes of failure from the testicle itself, these are much broader, these are much more common. These are probably account for the majority of cases that we see of male infertility. Well, probably the most important one to talk about is varicoceles. This makes up about 15 to 25% of the population in general will have a varicocele. The way you know this is it feels like a bag of worms in the scrotum. Typically, it's worse at the end of the day, especially men who stand all day at work. They may say that they get a little dull ache at the end of the day. And again, when they feel down there, they feel some dilated veins in that area. Now, among infertile males, it's been quoted anywhere from 35 to 60% of men will have varicocele. I think those numbers are a bit high. If you look at specifically what we call grade 2s and 3s, so ones that are easily palpable, ones that you can see through the skin. For example, that picture on the bottom right there, that's one you can see through the skin. Those are the ones that clearly are much more likely to benefit from surgery than, for example, if you just see it on an ultrasound. Those ones we know you don't benefit from surgery and really should don't need to undergo a procedure for that one. We don't know why they cause impairments in fertility. There are a lot of hypotheses as far as maybe it's a temperature regulation issue in the testicle. But we do know if you treat a varicocele, it improves the fertility of the man regardless. And on average, you're looking at about a 2.5-fold improvement in spontaneous pregnancies if you treat the varicocele. And again, not all men will need this treated. It really depends on other factors in your evaluation. And this improves various factors, including sperm counts, the amount that are swimming or the motility, as well as the DNA integrity of the sperm and other factors such as testosterone. Well, cryptorchidism, so there's about 1 to 7% of men less than 1 year of age will have cryptorchidism or an undescended testicle. Now, it may not be the undescended nature of the testicle itself that's causing the issue. It could just be the fact that if it doesn't descend, then there's an abnormality of development of the testicle since birth. Especially if you have 2 testicles that were undescended or you needed surgery to bring them both down, that puts you at a much higher likelihood of having a primary issue of the testicle, so it's not developing sperm normally. Sometimes we can bring a testicle down even later in life, and that can restore sperm. But in my experience, it's been if you have an undescended testicle and it's not repaired, then you'll have impaired spermatogenesis. And even if it is repaired, you still have issues oftentimes with the production of sperm itself. Obesity. This is one that is obviously reversible, and no question, obesity has a direct impairment on sperm. This has been shown in vitro as well as it's been shown in like laboratory type setting as well as in human patients for it. We know that improving obesity will improve spontaneous pregnancies as well as when you're using these assisted techniques such as intracytoplasmic sperm injection, which is that ICSI, or other techniques. Also, obesity is directly related to testosterone. We know if men have bariatric surgery, for example, they, on average, their testosterone will boost about 250 points. If you do just dietary changes alone, you'll see boosts in testosterone of 50 to 100 points or so. So the more adipose tissue or fat tissue you lose, the better off you are fertility-wise and testosterone for it. We don't have a good mechanism for this. There's the whole idea of epigenetics playing a role, which is basically what happens to proteins after they're transcribed and translated from the DNA itself. So we don't know exactly why it impacts it, but no question it does have an impact. Environmental factors. So there are multiple factors that we know contribute to infertility. Unfortunately, these are often hard to detect, hard to identify, and hard to make lifestyle changes. Air pollution, pesticides, others we know have an impact. Things such as cell phone radiation, we can prove it has an impact in a dish, but in a human condition, it's much harder to prove, and it's much more debatable if that has an impact on things. And the impact here could be hormonal, it could be direct damage to the testicle itself. Again, we don't know fully, but no question these do have an impact. Substance abuse. Again, this is another very reversible lifestyle factor that contributes to infertility. Among them, alcohol, tobacco, cocaine, marijuana are more common ones that do have a direct impact on fertility. And when you try to quantify how much it is, you look at alcohol, you're looking 13 to 17% is what the studies roughly show. Cocaine, men who use cocaine have a roughly twofold higher rate of low sperm counts or oligospermia for it. So these are reversible type conditions. Another one that I put under substance abuse, but could fit in other categories too, is testosterone. Usually when I see someone in clinic, I'll ask them if they take anything to build muscles. If you get anything from any store that is helping you to build muscles, there's a possibility that has some substance in there that is impairing fertility. And the reason that is, I think I have it a later slide, but when you give testosterone, it will impair the hormones that are responsible for fertility. So it'll feed back into the brain. The brain thinks it's making plenty of testosterone. It then shuts down FSH, shuts down LH, and the testicles atrophy over time. Another ways around this, but that is one common one that I'll see in clinic is a provider will start someone on testosterone and they have normal or zero sperm counts. You take them off the testosterone and suddenly it rebounds to normal. Vitamin deficiencies, these are relatively uncommon. And in general, I would say if you're wondering if you should be spending hundreds of dollars on multivitamins, don't. For the most part, they have very minimal benefits. There's a Cochrane meta-analysis, which is kind of the gold standard way of looking at studies, which shows there may be a slight benefit to using antioxidant type therapies, but it's based on very poor data, very minimal amounts of data. So in general, I tell people don't waste your money on these expensive ones. If you're going to take a multivitamin, get a cheaper one over the counter. The only time I really get concerned is if somebody has a very strict diet where they're avoiding some vitamins or others, and those ones we really should look at supplementing. And how it improves, there's hypotheses, but nobody knows for sure on it. Medicines is a very busy slide. I leave it up here just so you can reference it later. If you're on any of these medicines, these are ones you should consider getting on a different one or stopping because the improvements can be dramatic. You look at the data on these and sperm quality can improve in 93% of patients who stop them versus 12% who don't. Chance for spontaneous pregnancy, 85% improved versus 10% who don't. So if you're on one of these medicines, take a look, see if you can get off of it and change to a different one. There are a lot of syndromes that are out there, and for the most part, we don't detect these new. You're going to know these coming into it. Kallman syndrome is one of those that you can't smell anything. So if you put coffee up to your nose and you can't smell it, then that is a warning sign. It may mean that we need to look into things a little bit further. That also we can completely reverse with certain medicines that will restore your fertility. Prader-Willi, Lawrence-Moon-Bardet-Biedl, these again are very uncommon, but they are associated with infertility. Klinefelter, on the other hand, is a relatively common syndrome. Oftentimes, we'll detect this anew in someone who comes in to see us in clinic. The time we really get suspicious is if someone has no sperm, very small testicles, and gives us the history that I've always had a tough time putting on muscle. We get a testosterone that ends up being low often. And in these men, we do a simple chromosome test, and it will tell us if they are Klinefelter or not. It's important to know this because you're at higher risk for certain things such as diabetes, non-Hodgkin's lymphoma, even mortality, so it gives us more information. Also, it's important to know that oftentimes in these men, we can still find sperm. In the past, they always taught that, if you're Klinefelter, you can never find sperm, you need to adopt or use donor sperm, but oftentimes we can find sperm in these cases. And then there's other rare ones like Cartageners or these primary ciliary dyskinesias that can cause infertility as well. So testosterone, going back to the slides that I mentioned earlier, if you boost testosterone, so you give a pill or injection or topical or any form of testosterone for it, that shuts down this whole axis. So we see that the testicles themselves will atrophy, and essentially this is a very good male contraceptive. They even looked at it specifically for that use, is looking as a reversible male contraceptive. When you stop taking testosterone, it typically is reversible in men who have normal fertility. What we don't know about is men who have impaired fertility. If they go on high doses of testosterone, will they get back to normal or not? That we don't know. But in men who had normal fertility before, they get back to normal levels around 6 to 12 months after stopping. Well, cancer treatment. This is another common one that we see at Mayo. The type of treatment you had will significantly impact the production of sperm. If you had whole body radiation, for example, if you had radiation to the brain of certain areas, you had radiation to the testicles, that's going to impair it quite a bit. Certain chemotherapy drugs will also impair it, but it really depends on the dose. It depends how many treatments you had. It depends what types of chemo were received as to whether or not it's going to impact your fertility. What is important is after you're done with your treatments, abnormal sperm can be found in, for as long as even 24 to 36 months afterwards. So when couples are wondering, well, when can we try to get pregnant again? Usually we recommend waiting about 2 years or so before considering that. Another important thing is, let's say you do get pregnant. Couples always wonder, are we at a higher risk of having chromosomal abnormalities in the baby? And it's interesting when you look back at data of childhood cancer survivors, so ones who had chemotherapy and other things in their youth, they don't have higher rates of chromosomal abnormalities in their offspring than their equivalent, than people who are equivalent who haven't had chemotherapy. So it's very reassuring, I think, for many couples for it. Many men will choose to freeze sperm before they undergo treatments, though, in order to reduce the likelihood of not being able to find sperm later. So that's definitely, if you have a new diagnosis of cancer, something you highly should consider if you're going to undergo any sort of chemotherapy or radiation for it. Well, can you treat male infertility in these cases? So if it's a lack of testicular production of sperm, are there any options available? It's a very long discussion. It'd be a whole separate discussion, but I kind of broken it down into 3 cases. And one is we look at reversible causes. So can we fix a varicocele? Can we modify lifestyles such as obesity, alcohol, tobacco, things like that? Can we change any of your medications out? And are there any syndromes we can detect and potentially impact, such as Kallman's? So that's the reversible cause side of it. On the medication side, we look at certain things such as clomiphene citrate or anastrozole, HCG, other things. Can we boost your numbers? If you're really low numbers, such as no sperm or very low, it's not often that we'll get you to high enough numbers that you'll be able to achieve a pregnancy. But if you're borderline, if you're right in that range where you could achieve a pregnancy, we can definitely improve your likelihood. There's a meta-analysis or an analysis of multiple studies which shows that taking Clomid can boost your chance for fertility or chance for pregnancy by about 2.4-fold, and even higher if you use certain doses of it. So no question we can improve fertility with medications in many men. And then finally, we determine if you're at best suited for assisted reproductive techniques such as in vitro fertilization or intracytoplasmic sperm injection. And in these cases, often we need to get sperm directly out of the testicle. That's where we look at these testicular sperm extractions. Very often we can do this in the office without any problem. And in some cases, we need to do something a little more aggressive in the operating room to try to find it. When we look at the medications, what do they do? So aromatase inhibitors such as Arimidex, that's going to block this aromatase. Selective estrogen receptor modulators like Clomid, that'll block estradiol. So those block the feedback inhibition on the brain. It kind of tricks the brain into thinking that I need to make more sperm. So, and again, HCG, similarly, it acts like luteinizing hormone here. All of those therapies will boost production of testosterone as well as sperm in select men. When that happens, again, you get hypertrophy or growth of the testicles, and oftentimes we can boost the quality as well as the number of sperm and sometimes motility of them as well. Well, what can you expect? Let's say you decided, okay, I need to come in and get an evaluation. What is it I'm going to undergo? What's going to happen to me? It'll vary by providers, of course, but one of the most important things we do is an exam. So we'll feel for the tubes, the vas deferens, make sure that they're there. We'll check the size of the testicles. We'll look for any other abnormalities that may be causing the infertility. We'll then typically get at least one semen analysis. Ideally, we'll do 2 semen analyses because they vary so significantly. And then oftentimes we'll get blood tests such as FSH, LH, and testosterone. And that's usually an initial sampling of what we do. Based on those results, we then can usually classify you into different categories as to whether or not you need other evaluations. Some of those other tests can include an ultrasound to look for blockage. We can do other blood tests such as karyotypes or Y chromosome microdeletions or other things, sometimes looking for cystic fibrosis. It really differentiates after that. And those are on a case-by-case selected basis. Well, just a few final comments before we end, or before we get to questions, I should say. Many patients won't have a reversible cause of infertility. So when you come in, the high likelihood is that you won't have a reversible cause of infertility. We're just trying to optimize your fertility in those cases. Not all benefits are going to or not all patients are going to benefit from medical therapy either. A lot of men come in and want to be on a pill, want to be on something that's going to improve their fertility. There's definitely a percentage of men who aren't going to benefit no matter what we give to them medication-wise. Very often, infertility is due to genetic factors on the male side of things. And even in many cases where we can't find any sperm in the ejaculate, we can still find it in the testicle. So if someone comes in and has no sperm in the ejaculate, all hope is not lost by any means. We can go in and find it in the testicles in many, many cases. One little more on a personal note, I would say, is buyer beware for this. So the one tough thing whenever you have a pay for or a fee for service model is that there's a lot of chances to take advantage of that. And there are many unnecessary treatments that are given that I frequently see among patients. And every industry has people who try to engender or capitalize on hope. But what I would say is it's in many cases worthwhile to get a second opinion in regards to fertility, especially since many of these procedures are often cash pay and insurance doesn't cover them. So before spending tens of thousands of dollars and many years, sometimes it's worthwhile to get a second opinion on things. In summary, infertility is very common. Male factor is identifiable in about half of the cases. There are many benefits in evaluating the male beyond just the fertility side of things. Many times if we find an obstructive cause, these are reversible. When we find a non-obstructive cause, these are often very treatable. And even when these behavioral changes or medical therapies aren't effective, we often still can use assisted techniques such as in vitro fertilization or intracytoplasmic sperm injection to help achieve a pregnancy. And with that, I thank you very much for your attention. We'll now turn the time over to answering some of your questions. And I thank you in advance for the questions. I'm looking forward to see what they are. And even after we're completed, you're welcome to contact us anytime with additional questions. We'll be happy to get back with you and respond to them if we're not able to complete or answer them in this time. So looking at the questions, one of the first questions here, when should our family consider coming to Mayo versus seeing another physician or location? And I think the physicians at other locations are often just as good, or I don't think there's anything unique in many cases, as long as you get with somebody who does a lot of whatever you're seeing. So in the case of fertility, if you get with somebody who specializes in fertility and does it very frequently, I think you're very safe to do that. The times I would usually seek a second opinion is anytime someone's recommending either very, very expensive surgeries or expensive therapies, or if you've tried for some time and haven't had success with it, then I think it never hurts to get a second opinion for it. If you're in a town or location where you don't have someone available who does infertility regularly, then in that case, I definitely think it's worthwhile. It's also very worthwhile always to seek both a male and a female evaluation. We see it very often where someone will be pigeonholed on one side just to realize that the other couple or other partner in the couple needs to be evaluated as well. Now, Mayo, of course, has very specialized techniques. So Mayo has something called an embryoscope, which is not commonly available elsewhere, and that increases your success rates with assisted techniques. We have microscopic vasectomy reversal. We have robotic-assisted vasectomy reversal. So we have a lot of advanced technologies and techniques. So you're definitely always welcome to, but that's really a personal choice on that. Second question, tight-fitting underwear, laptop. So I get this one all the time. People will say, Should I be changing to boxers? Should I not have the laptop on my lap? Should I be stopping bike riding, bicycling? Should I skip out on hot tub saunas, things like that? We know that high temperatures are bad for the testicle. So if you increase the temperature of the testicle, no question it impairs sperm production and functionality. We also know that if you cool down the testicles, they do better oftentimes. But what we don't know is if you're in situations such as sauna, hot tub, laptop, we don't have really good evidence showing that impairs sperm production itself. So even though a laptop increases temperature reduces sperm count, we don't have direct evidence that having a laptop on your lap all the time will reduce sperm counts. Same is true with saunas. Again, we know temperature is bad. Sauna increases temperature, but the sauna doesn't necessarily reduce your sperm count for it. So in general, men who come in and say, look, I sit all day and tight-fitting undergarments, things like that. In those cases, oftentimes they'll say, well, see if you can get around, walk around a bit more, looser fitting undergarments. There's no harm in those for sure, but that one's definitely not a definitive. We don't have very good evidence for. Good question. How often should we be having intercourse? This one's still under debate, I should say. So recently there's been several new studies that have challenged kind of the age-old feeling that it really should be every other day or something along those lines. When you take your partner's total cycle, so if your partner's total cycle is, say, 28 days, subtract 14 from that, and that's the time of ovulation. Ideally, you want to be having intercourse every day for the 5 days before that. Again, it's still debatable. Some will say every day, some will say every other day. But when you look at the production of sperm, those 5 days before are your critical time point. Days after ovulation are not going to result in a pregnancy. But up to 5 days and maybe even longer, so potentially even 6 or 7 days. We don't have good data for it, but there's anecdotal reports that sperm can survive in the female tract for that whole time period. So really you want to be having intercourse every day during that time. Now I do believe in select men, so men who have very low volume ejaculates, that every time they ejaculate they get the same low volume amount. Those select groups may benefit from even more frequent intercourse than that. The other thing too is you don't want to take a break for all times except for that window. We know if you wait too long, so if you wait 11 to 14 days, we know that sperm start getting impaired. The motility goes down, so you want to have more regular ejaculation than that. And outside of your normal window, ideally you still do want to ejaculate relatively frequently because that may boost production of sperm over time. So again, the key is about 5 days before the time of ovulation, and you can use kits that you get over the counter and other things to see when you're ovulating, to know when that ideal time is, but that's really your optimal time. Are men becoming more infertile over time? So this was a debate, especially the last 10, 20 years. Multiple epidemiologic studies have looked, over time, are men becoming increasingly infertile? Some have blamed it on estrogens and the environment, any number of things. And the best answer to that is probably that it's very debatable. More and more we're getting evidence that that's probably not accurate, that men have probably been maintaining their fertility. But again, it is a very debatable issue, and we don't have a great answer. And that's why sometimes you read in the news, men's sperm counts are getting worse over time, then 2 weeks later, men's sperm counts are remaining, stable over time. And it's just that you have contrasting studies that keep coming out. And so at this point, it's not one that you can answer easily. They're hard studies to do when you're looking 20, 30 years down the line. Male age. This actually is a very good question. So historically, we always said, female age, that's the key thing. As the female gets older, particularly after age 35 and especially after age 40, your risk for chromosomal abnormalities really start to go up, fertility really declines. And we always said, well, men, their fertility is maintained essentially forever. But more and more we're finding that's not true. So male fertility does decline a bit over time. But more importantly, we're starting to see abnormalities in offspring. So men who are older, their offspring tend to have a much higher rate of bipolar, of autism, and other schizophrenia and other psychologic disorders. So we don't know why. Again, it's still very early. These are just over the past couple of years where this has now come out. But we are noticing that men, their contribution to the offspring is significant, and as men age, that risk does go up as well. We don't have very good time points. People say, well, what age does that go up? We don't know yet as far as how much it goes up per year and what your risks are per year. And the relative increase is anywhere from 2 to 10-fold higher rates of some of those conditions with it. Okay, let's see. I'm going to have to read over the camera here. My husband and I have been trying to get pregnant for more than a year. I was evaluated by my doctor and told I should be able to conceive. How can I convince my husband to get tested? Well, that's a good question. It's a good kind of social situation question for sure. But I think on the male side, once they realize that it's a very easy test to get done, and that oftentimes we can detect other things, such as cancers, increased rate for mortality, those give you much stronger, I think, ammunition to have them tested for it. On the male side, one of the most important sides is just getting the semen analysis. And oftentimes in certain partnerships, if they have any reasons to not be able to give a sample, partners can come in and help collect the sample. So there are other ways we can get around some of the testing. But also on the male side, I think there's benefits because oftentimes you can detect if they have low testosterone, other things that are very treatable that can improve many symptoms and prevent future long-term issues with it. There's several different media things out there that can give further, encouragement for it. But that is a tough one in general if one of the partners is hesitant to be tested. So great question. Okay, if my partner gets, I think it says pregnant after vasectomy reversal, are there any, added risks involved? Is the sperm just as healthy as it was before my original vasectomy surgery? So it's a great question. After reversal, and one addition to this question too is, are the sperm immediately as good after reversal as should I be waiting some time to kind of flush out some of the old sperm for new ones? Once you reverse the vasectomy, the ones that are motile, the ones that are going to be able to swim, those are essentially as fresh a sperm now as they would be in the future. So you're not at higher risk for any sort of abnormality with offspring for it. Now, on average, after vasectomy reversal, it takes 12 to 17 months to get pregnant. Now, the fastest, our record's 2 weeks, which I still don't understand because we tell them not to even have intercourse for 2 weeks. But it can be sooner, although the average does take about a year or so. The longer the testicle's been blocked, the longer it takes everything to wake up. So just like a pump, if you block a pump for a long period of time, you can start getting leakage and damage to the pump itself. Same with the testicle. The longer it's been blocked, sometimes the more it takes for that to become unblocked and to return to normal. But yeah, you don't have to have a certain time period where you're avoiding intercourse or anything like that after. The only time I would say that is immediately after healing from the surgery. You may want to give it a little bit of time just so that it doesn't pull on the tubes at all. It's such a fine area of suturing back together that anything that can damage it could potentially worsen the fertility over time. Should I have a semen analysis even though a doctor identified a problem with my wife? So I saw 2 patients today who had this exact issue. They'd been working up the patient's wife or patient's partner for quite some time, about 1.5 years in one case, about 1 year in another. And she'd been undergoing multiple treatments. They'd done Clomid. They were looking at other therapies. And finally, they got a semen analysis in him and found out he had no sperm. And so almost all of the guideline bodies that are available and that are out there recommend getting both the male and female evaluated simultaneously. So the right way to go is if you've been trying to achieve a pregnancy for a year unsuccessfully, then you should both get evaluated, at least with some screening tests. If, on the other hand, you have risk factors, so polycystic ovarian syndrome, endometriosis, on the male side, varicoceles, older age, so it's, let's say, age 35 or above. In those cases, if it's been about 6 months, you should consider coming in and getting evaluated sooner for it. So universally, it should be something that both men and women get evaluated for. And again, that's not the current trend, but that's the ideal with it. Could you tell me more about medications that can be used to improve the chances for spontaneous pregnancy? Is there a reason I can't take these medications if I have other health issues? So there are a lot of medicines out there that can improve your chances spontaneously. What I would say is ideally you want to be in the right group, meaning that if you have no sperm in your ejaculate, you can take these medicines. They may improve your chances for in vitro fertilization success or intracytoplasmic sperm injection success. but it's less likely to result in a spontaneous pregnancy. Usually for a spontaneous pregnancy, we ideally want to see somewhere in the order of 5 million swimming sperm per ejaculate. And if you're all the way at 0, it's unlikely that we're going to get you that high for it. But again, there are other benefits to taking the medicines in that they may improve the overall quality of the sperm that you recover, and oftentimes they may increase the likelihood that we can find sperm in cases of men who don't have sperm at all. Probably the two most common that are used are clomiphene citrate or Clomid and Arimidex or anastrozole. Clomiphene citrate has very few side effects. There are multiple prospective trials, so there are multiple trials that have looked at this over time, some of them even several years for it. And those have shown, again, very well tolerated in men. It's different than in women. In women, you can only take it for a certain period of time and you have to cycle off of it. In men, you can take it for many, many, many years. In fact, men who need testosterone supplementation, who want to maintain their fertility, we routinely will use this agent as opposed to testosterone and other things to help maintain their fertility. Dosages range from anywhere from a half a pill every other day to a full pill every day for it. And on average, by taking Clomid, you're looking, again, about a 2.4-fold increased risk or increased rate of spontaneous pregnancy. And again, that's in men with low sperm counts. We don't have good data in men who have normal sperm counts if it increases their chances or not. So the time I typically consider giving it is if they have a low count or low motility. Those are the men that I'll consider supplementing. If you go on one of those therapies, we usually want to get blood tests routinely. We want to make sure your blood doesn't get too thick. We want to make sure, depending on your age, your PSA doesn't go up too much. We also want to measure your testosterone, your FSH, make sure you're responding appropriately, because a percentage of men will get an opposite effect with it. Arimidex or aromatase inhibitors, in general, I haven't been as big a proponent of this. Now, this is debatable, so if you go to a different fertility provider, you'll get a different opinion on this. But aromatase inhibitors, there's a 1-year study out which shows that it decreases the bone mineral density in men. We know that estradiol is the component that is responsible for most of the non-muscle building effects of testosterone. So when you impact estradiol, when you take Arimidex, you cut down the production of estradiol, so you change the testosterone to estradiol ratio. The problem with that, though, again, is when you reduce the estradiol, you start to reduce the impacts of estrogen in the body. And that the one study I'm thinking of in particular that's a year out that looked at placebo versus Arimidex, those men did have reductions in bone mineral density for it. Also, anecdotally, in men who've been on testosterone supplementation who then take Arimidex in addition, they almost not universally, but a high percentage of them come back and say that their symptoms are much worse after being on Arimidex. So I think there are other factors with it that we would see with longer term studies that are out there. And in the setting of having a good alternative, such as Clomid, that has kind of the opposite effect, it improves bone mineral density, improves a lot of these things. To me, that's the one I typically consider. Again, that's very debatable, though. Other things such as HCG, an injection that you can get, HMG or FSH type equivalents, you can do those. I tend to reserve those for more select cases of men who don't respond to Clomid. And the main reason is they're expensive. You have to self-inject. They're harder to administer. So those are more select cases typically for it. But great question. And again, more than happy to go into more details if you have more specifics on it, because it's a big topic. Question 11 here. My wife and I really want to have children, but I was just diagnosed with cancer. Could you tell me how fertility preservation works? Yeah, great question. Thanks for asking that one. So fertility preservation, the idea behind it is you want to store up as much sperm as you can before you start undergoing treatments. Now, it depends on the type of cancer. It depends if you're going to need chemotherapy, if you're going to need radiation. And it'll depend on what we anticipate the effect on the testicles themselves. Now, cancer itself will impair sperm production in many men. So oftentimes men who are completely fertile before, they'll have a new diagnosis of, say, testicular cancer or something. They'll come in and will find very few sperm. And it's probably the effect of the tumor itself or the cancer itself that's impairing that. To get it, typically we'll have an initial consultation. We'll go through some of the information behind it. We'll fill out all the paperwork. The paperwork for these is incredible. It's like buying a house, it seems like. After all the paperwork, we typically get blood tests to look for HIV, hepatitis B, hepatitis C, mostly because if you don't have those, you can store it for cheaper more readily. Then typically we like to get at least 3 semen analyses or 3 ejaculations. The reason for that is if you don't have very many sperm, we want to freeze up as many vials as we can, because every time we unthaw one vial, that vial is now done. So if we can store up 8 to 10 or more vials of sperm, each one of those can be used for an attempt, such as in vitro fertilization or intracytoplasmic sperm injection later. Now, costs with these vary depending on where you're at. At Mayo, typically, if it's a cancer diagnosis, oftentimes they'll cover a portion of the freezing itself. But long-term storage typically runs in the $250, $300 range per year to keep it frozen. And usually what I tell patients is, once you freeze it, if you're looking 1 to 2 years later, I would get a repeat semen analysis. If that shows sperm is returned, then we can just discard your other samples because you wouldn't need them any longer, assuming you don't need any further chemotherapy or anything like that. But again, it's a great question, and it's always heartbreaking to see the cases when people do come in for fertility preservation. One of the caveats I would say is if it's a young male before he's gone through puberty, oftentimes we don't have a great way to preserve for it. There are experimental protocols out there that are saving tissue, but there's never been any studies which have shown that this can be used, and so it's only on experimental protocols that they'll typically save tissue for that. But great question. All right, DNA fragmentation index. So if a male patient has a high DFI or DNA fragmentation index, does that increase the risk of miscarriage or genetic problems in the offspring? This is another one of those debatable topics, and I'll expand this into all of the other very specific tests. So with fertility, there's a huge number of what I call miscellaneous tests you can get done. And these, anything from hamster oocyte penetration tests to the DNA fragmentation index and others, these have very limited roles, though, I would say, because often they're very expensive and they don't change what we do treatment-wise. So if someone comes in and gives me a result back on their DNA fragmentation index, it's not going to make me say, oh, in that case, I'm not going to do Clomid, we're going to use this other agent instead. It also is a very poor prognostic indicator. So it has not been shown consistently in studies to have very good prognostic information. Now, if you're using assisted techniques, such as in vitro fertilization or intracytoplasmic sperm injection, sometimes the DNA fragmentation index can tell us that you're going to have a higher rate of miscarriages than if you didn't. But the problem with that is that you don't use DNA fragmentation index as a part of the pre-implantation genetic testing. Now it's getting kind of a little too detailed maybe, but if depending on risk factors, oftentimes we'll recommend that you undergo chromosomal testing as part of the assisted reproductive techniques. In other words, we successfully create however number of embryos. We take one cell from each of them and identify these ones have multiple chromosomal abnormalities, these ones don't. And that's going to be a much more important test than, for example, the DNA fragmentation index. Fragmentation index usually looks at individual sperm, but after you've sampled that and we say, well, you've got a percentage that are abnormal DNA, we can't then go back in and select the ones that didn't have the abnormal DNA. So it ends up just being, it's interesting, it's information, it's what we call academic, so it helps people write papers later and things like that, but it really is just money out of your pocket, and it doesn't have a major impact on decision making of any sort. Question 13, what does it mean if I have severely low sperm count? So there are different terms we use for these. Azospermic is going to be where we say you have no sperm, and then there's different terms that people use for severe low sperm counts. Probably the most commonly used is just classifying people into oligospermia. And those, the definitions for that vary over time. These come from the World Health Organization, who have defined what we consider to be a low sperm count. And essentially less than 15 million per ml, less than 39 million total per year ejaculate we'd consider to be oligospermic. 0 sperm we'd consider to be azospermic for it. And these just help us to categorize and classify people. No question, if someone's azospermic, you're higher risk for certain things than someone who's oligospermic. For example, if someone has some sperm, it's much less likely that they're going to be Klinefelter, for example, because they'd have to be what we call a mosaic of Klinefelter. So it does help us to differentiate what type of treatments we can do. Oligospermia, or low sperm counts, or even severely low sperm counts, those are ones who are going to respond a little more to medications than those who are azoospermic. But you don't really need to differentiate clinically severely low sperm counts versus low sperm counts. If you're not getting pregnant and you have a low sperm count, that's usually good enough information there for it. Looks like we have time just for a couple more questions. Does insurance cover fertility treatments? That's a good question. Usually not, is the best answer. It depends, I should say, on what we discover. So if we find, for example, that you have Klinefelter syndrome, if we find you have low testosterone, that will put you in a different diagnosis category. Or if you come in with testicular pain or other things like that, oftentimes insurance will cover some of those evaluations. But if we're looking specifically just for fertility, it's much rarer for insurance to cover those things. And so costs become a big issue for it. And that's where I think it's always worthwhile to shop around and to cost compare on things, because if you can get the same benefit looking at various areas, you might as well go with the one that can do it for less expensive. When I started here, one of the most important things I pushed for was to make our costs lower. And after about 2 years of emails back and forth, I don't know if I'm supposed to say this or not, but it's out there. This is live. After 2 years of emails, I got our prices down dramatically for it. And for example, vasectomy reversal went from like $35,000 down to $7,000 or $7,600, and extracting sperm went from $20,000 down to $2,000. So it's a much more reasonable thing. Told my wife I'm going to put that on my grave, that I got the prices down for it. But one of the main reasons I went into infertility is the greatest joys in my life, no question, are with my wife and children. And when I see couples, I ask them to just send me a picture of the baby after. That's kind of, and that's the biggest reward for me. Is I have a little board in my office where I keep pictures of all the babies and report cards and things like that people send in. So that is a big factor, a big issue for many couples. I have seen some employer plans that will cover a portion of in vitro fertilization or intracytoplasmic sperm injection. Those typically run about $16,000 for the first attempt, about $5,000 for each additional attempt. Usually it takes about 2 or 3 attempts to achieve a pregnancy. So those are kind of costs that you can expect when you're looking for the whole evaluation of it. And we usually will discuss individual costs of specific tests in trying to make the decision should you undergo them or not. Question 15, does Viagra affect male fertility? Will it increase or decrease sperm count? So on the limited data that we have for this, the answer is no. Viagra is purely something that helps on the erection side of things. Now, it does have some, for lack of a better way to define it, antioxidant type properties. So it does have some benefit in stabilizing membranes. So there may be some benefit towards fertility, but there's no harm in taking it for sure. And again, when they did the original trials on that, of course, they didn't pick couples and put them on Viagra and see if it impacts sperm or not. But that tends to be one of the medicines that we don't worry about as far as fertility. So, well, with that, I thank you very much for your time. Again, we'll try to get to any and every question that we did not get to in the following week or so. So maybe a little bit of time till we get back to you. But I really appreciate you joining us for this. If you have any questions, again, don't hesitate to contact us. Again, this is one of my lifelong goals as far as on the male fertility side. I really enjoy helping couples to have children. So please don't hesitate to call me if you have any questions. With that, I thank you for your time.